We have a few kidney disorders, and then the last topic for today will be the alternate modalities for nutrition. Polycystic kidney disease. So this is a genetic disorder. So same thing as same concept with sickle cell disease. Okay. So this is passed on from one generation to the next. There are two forms of PKD. There's a dormant and a recessive. So what happens in both cases is the patient's kidneys develop numerous fluid-filled cysts. And as these cysts develop, they of course destroy the nephrons. Okay? So now instead of you having nephrons, what do you have? Cysts now. Okay? So of course, can this lead to chronic kidney disease? Yes, so this will be one of the causes that lead to dialysis, right? So the patient's kidneys will fail here. Both kidneys will fail. As I mentioned, this is genetic, so this is inherited. So part of the management will be, of course, genetic counseling, okay? There's again, autosomal dominant and recessive. The most common type is the dominant type. The problem with the dominant type is the patient doesn't have the disease at birth. The recessive type, the patient has PKD at birth. It's even present during embryonic development, meaning let's say we test the fetus inside, we can already see that the fetus has PKD. The dominant one, which is 90% of the cases, we don't. The patient is born normal, they grow up normally, they develop the symptoms when they are already in their 30s. Average age for patients with PKD, here, they can live up to 54 on dialysis, no dialysis, not so much. Okay, so the patient is born not knowing they have PKD until they hit their 30s now. They're in their 30s, and then now they develop symptoms of chronic kidney disease. And they go to the doctor, do an ultrasound or a CAT scan, then we'll see the fluid-filled cyst. Okay, so it's a sad disorder, okay, the dominant type. Actually, either one. Sad because the patient will lose the kidneys. There's no cure for this. The patient will go into end-stage kidney disease eventually, and I'm not repeating hemodialysis, okay, or the signs and symptoms of chronic kidney disease. That's basically what's going to happen. But for PKD, these are the manifestations. The patient will have blood in the urine, hypertension, again, signs and symptoms of chronic kidney disease. But the patient will have blood in the urine. The blood here in the urine is from the cyst, that some of these cysts will eventually rupture and cause bleeding. Okay, that's the reason for the hematuria. I repeat, no cure. That's all we can do here. Is conservative management, meaning we treat the chronic kidney disease. And because again, this is transmitted from parent to offspring, so what do you include in the management? Genetic counseling. Do you really want your kids to have this disorder? You want more of you? Okay. Let's say Helder has PKD. You want more Francois Jr., Francois the third, the fourth to have PKD like you? No. Okay, right. If you have money, you can do in vitro, meaning you can do selective. Okay, meaning you can fertilize a few eggs and then pick the ones that don't have the gene, and that's what you implant. Okay, if you have money, if you can afford it like that. Or granting also that that's not against your morals or everything, there's no ethical concerns about that type of conception, but I mean, it's up to you. But again, make a decision. Okay, this is gonna be passed on from one generation to the next, right? And that's all I can say about PKD. Any questions? The the kidney, by the way, here gets big, okay, because these cysts are big. So the kidney will grow twice or even 3 times its size. So the kidneys can be palpable. Okay, so when you palpate the abdomen, now the kidneys are palpable. They grow so big. That's it. Let's review a UTI because you did UTI in MedSurg 1, yeah? Okay, let's go to urinary. Okay. UTIs. So this is a review again. So this is an infection, lower urinary tract infection. Let's look at the risk factors. So who gets UTIs? High risk are females, older females, higher even if you're diabetic, you're pregnant. Urologic disorders, meaning these are patients who have had a stroke, for instance, or let's say a spinal cord injury, okay, paralyzed, because what happens to those patients? Can they pee normally? No, now we have to catheterize, right? So therefore, they're higher risk for infection. Plus, if you're older or let's say you're paralyzed, can you really clean down there? No, because you can't feel it, right? So we tend to neglect. We call that unilateral neglect syndrome. Okay, so after a stroke, for instance, you can feel your arm. So that happens. Okay, you can't take care of a body part, then they get infected. Gout, or let's say you have bladder problems. You're either incontinent, or let's say your bladder doesn't completely empty. Okay, so those are risk factors as well. Immunocompromised, and all the rest here. And then including catheterization. We will talk about CAUTI, catheter-associated urinary tract infection, separately. All right, so long story short, of course, the urinary tract is sterile. However, the meatus is not, right? So we have in the female, for instance, so only a few centimeters separate the distance between the anus, the vagina, and the urethra. So therefore, are there microscopic fecal material in that area? Yes, especially if you don't wipe from front to back, right? Some people, let's say kids, for instance, wipe from back to front, or let's say after intercourse, no, they don't wash, before and after intercourse, right? I had a student before that argued with me, no, you only wash after, you don't wash before. Whatever makes you happy, man. But the book says you have to wash before and after. Right, so the most common route, of course, is from the perineum, yeah? So other factors like hygiene, for instance, plays a big role, okay, in prevention. As we want to prevent rather than having to treat UTIs. Manifestation, it varies from patient to patient. So these are the commonly reported symptoms. By the way, there's two types here. We have a uncomplicated UTI, which is usually treated with 3-day course of antibiotics, or we have a complicated ones, which can require 7 to 10 days or longer of antibiotic treatment. So these are the manifestations. Take note that in the elderly, do they usually have symptoms? None, right? None whatsoever. The only manifestations they'll have is probably the mental status changes. They get more confused than usual. Okay, if they have dementia, for instance, or they're a little oriented and down they get confused. Okay, there's a change in the behavior. Right? And here are factors that increase the likelihood of UTI in the adults. Chart 2049-2. I'll go straight to the diagnostic tests. Of course, we use urine sample. So simple urinalysis will reveal the presence of bacteria or whatever organisms. then we need a culture in order to grow the organism and then identify which antibiotics are the organism is sensitive to. Okay. Most common is, of course, in the elderly, especially, is E. coli, right? Meaning it's contamination from the rectum. So here, E. coli is most likely the community acquired, or it can also be the organism responsible for hospitalized or institutionalized patients, being those patients in a nursing home or in a hospital. So I mentioned urine cultures and the urinalysis management. There are specific antibiotics used for UTI. Table 49-1 tells you the commonly used ones. You're lucky because this one doesn't have the nursing considerations, but I highly encourage you to read it for the NCLEX. Your table on this textbook, though, doesn't have that anymore. So all I can test you is what it's for. All right. For instance, you have here a set of antibiotics. You have the cephalosporins, fluoroquinolone, and you have the specific generic names here. Right? And what they're for, are they for regular UTI or uncomplicated UTI? Fluoroquinolone, the Levaquin, this is for uncomplicated UTIs, a simple UTIs, meaning 3-day course and you finish. Let me just remind you the last one here, phenazopyridine, brand name Pyridium, is not an antibiotic. Okay, so if you look at the columns, what is it for? Okay, for the pain, the bladder pain that the patient feels with having a UTI. And common question on the NCLEX, of course, is this drug turns the urine orange. Okay, but that is a harmless side effect. It doesn't cause any long-term problems. It does stain your underwear permanently, so don't wear your best underwears while on this drug. Use the one with holes, the ones you're about to discard that are 6-10 years old already. So wear those. Or at least wear anti-shields maybe, okay, while on this drug. Because you always get, drips of urine, right? And it will stain, your favorite undies will be ruined. All right, let's go to the, of course, complications I'll separately discuss because they're in a different section actually. But some of them are mentioned here. For instance, urosepsis. So a UTI can enter the bloodstream and then cause sepsis. We'll discuss sepsis as the first topic on module 1 next semester. So UTIs are not minor conditions, okay? You have to treat a UTI because otherwise it will go from a local infection to now a systemic infection. You could die. Here's your prevention, okay, hygiene. When do we wash the perineum? Okay, before and after each bowel movement. Who else? Okay, voiding also. When do we void? Before, or let's say may not be before, but immediately after intercourse, right? Okay. The interventions also, besides the antibiotics, they also mention something here about what to nutrition-wise. Okay, let's say about herbal supplements such as cranberry, for instance. Okay, what beverages to avoid to avoid irritation of the urethra. Okay, please read the details. All right, I won't read them. CAUTI. So for CAUTI, let's go to that section because it's a separate, since it's not here yet. So let's talk about the next topic first, which are pyelonephritis. So for our purpose, we will only test acute pyelonephritis. We will not discuss and test chronic pyelonephritis. However, I'll just use the comparison, okay? So what is pyelonephritis? Infection of the kidneys now. Which part of the kidneys? The renal pelvis, the tubules, and the kidney parenchyma itself, okay? So usual cause here, if it's acute, it's usually caused by a UTI first. So the patient had a UTI, let's say did not have symptoms or had symptoms, ignored it, delayed treatment. So now what happened? The infection swam up to the ureters all the way to the kidneys. So from the lower urinary tract reached the bladder, and then from the bladder went up to the ureters and then reached the kidneys. Or it could also be in other cases wherein the infection may have started from the bloodstream, not necessarily a UTI, but majority of acute pyelonephritis started as a UTI first. So signs and symptoms, look at the manifestations of pyelonephritis. It has manifestations of a UTI. Okay, that means most pyelonephritis, acute pyelonephritis cases have started as a UTI first. However, since the patient now has a systemic infection, right? Because it reached the kidneys, so it may involve systemic manifestations now. So now the patient has nausea, vomiting, headache, malaise, and of course painful urination. And here's the inflammation of the kidneys. The patient now has low back pain or flat pain. Okay? And then of course, when you test the urine will be positive for a UTI. Management is antibiotics. So the patient has a UTI, so one or more of those antibiotics in the table we saw earlier. However, since this is now pyelonephritis, the patient will now require other antibiotics as well, not just for UTI. So yes, you'll get UTI antibiotics, but then also other antibiotics for the pyelonephritis. Teachings, of course, what do you teach for a UTI? So same thing, okay? So teachings we already had at the chart earlier. So same thing, hygiene, hydration, okay, not to delay urination, for instance. Chronic. To compare acute from chronic, let's describe briefly what is chronic. So this is caused by repeated bouts of acute pyelonephritis, which can lead to chronic pyelonephritis. However, most patients who develop chronic pyelonephritis usually have some problems with their anatomy. Okay, so for patients, for instance, who get frequent UTI, because it makes sense, right? Because this is caused by repeated bouts of acute pyelonephritis. And what's the cause of acute pyelonephritis? UTIs, right? Okay, so therefore, why did this patient have frequent UTIs? Maybe there's something wrong with their anatomy. Maybe there's a fistula. Okay, so maybe there's an abnormal connection between their bladder and their bowel, maybe. Okay, so it could be that. But maybe there's a connection between their anus and their vaginal canal, for instance. So who knows? Okay, so it's usually that's usually the case with chronic pyelonephritis. If it's not, I mean, why would someone again have such frequent bouts of UTIs? Yeah, unless the patient just neglects hygiene forever, right? That could be it. But look at the manifestations of chronic pyelonephritis. Is there an infection? No. Okay, so here has no symptoms of infection unless they have an acute pyelonephritis. But if it's chronic pyelonephritis, are there manifestations of a UTI of an infection? No. Here, no symptoms of an infection. But what do they have instead? Fatigue, headache. Are these signs of an infection? Are these manifestations of an infection? one I highlighted? No, because what are the signs of infection? Yeah, you have fever, malaise. Okay, yeah, none of that. Okay, none of that in chronic. So since this chronic pyelonephritis can lead to CKD, then it would be management of CKD. Here, the hypertension that develops, what happens again when you have CKD? What happens to uh your potassium levels? Increases. And that's about it. Any questions on acute and chronic pyelonephritis? All right, let's go now to, let's look at a few problems with, where's the COTI again? Okay, let's go to page 16, 17. All right, so COTI comes from indwelling catheters. So first of all is, how do we prevent it? Well, we can't 100% prevent it, but these actions are part of your COTI bundle. Okay. COTI bundle. So what are bundles? These are core measures from Joint Commission. So Joint Commission has core measures for most disorders. One of them is a COTI. So when you chart your shift by shift assessment on patients who have a Foley, this will be on the drop-down menu. Okay, so it will start with assessment and what are your interventions. It will ask you every shift, is this really necessary? Why is this in there? Okay, so did you use this? So it will ask you, and you have to answer yes, of course, because if you say no, why would you say no? Yeah. So of course you have to do this. Okay. That's why we're very strict with the skills lab. Okay. So I make sure you perform the skill properly, because that's the first step. Okay, you use strict aseptic technique during insertion. And we secure it. We don't want the catheter to move. So that's why we have a stat lock. Inspect the characteristics of the urine. Do pericare, right? Now in the hospital, this perineal care can be soap and water, but it can also be chlorhexidine. In fact, some hospitals, let's say, I've seen them in Montefiore, for instance, they use wipes, okay, specific number of wipes. How do you use it? They have like 4 or 5 wipes for patients every shift. Okay, and also it's not really just every shift; it's after every bowel movement. Why? Makes sense, yeah, because there's contamination every after a bowel movement. Okay, whether the patient's incontinent or not. So of course, there you have to do the quality bundle as needed after every bowel movement and at least once every shift. Maintain a closed system, meaning don't disturb. Remember when you open the catheter, is the catheter separate from the bag? No, it's already pre-connected, yeah? So do not disconnect it, okay? Leave it in a closed system. Because when you disconnect it, then you get in trouble. You get contamination now of the system. And most importantly, discontinue. So this is what I mean by a notice, a warning, a dialog box will pop up every time you open this patient's chart. It's asking you, patient has a Foley. Indicate why is it still there. You have to answer that, because otherwise that dialogue will never go away. Keep asking you, answer this. Why is this clutter in here? Okay. So you have to answer, oh, patient still needs it for this reason. Okay? And then if you say yes, he'll ask you, well, who's the doctor? Who's the doctor that ordered that it still remained? You have to put the doctor's name there, all right? Understand? Why is this all in our charting? Because of CAUTI, okay? CAUTI is serious. Okay, you get CAUTI, do you get reimbursed? No. Can the patient die? Yes. All right, we'll discuss suprapubic catheters another day. And I think that would be it. I think we covered your double check. The hydronephrosis section of your blueprint is not in this textbook, so you can disregard that part, as well as the strictures is not being mentioned. Right? So within the dysrhythmias and endocarditis, we did PKD, yeah? UTIs and CAUTI. So you can disregard the hydronephrosis and hydroureter, because this edition of your textbook doesn't have it. So you can disregard that part, right? Right, so the last topic for next week is just the nutrition. Okay, let's go to, there are two sections here.